and treatment. Start with Dr. Mostafa Heidar, and his topic will be fine needle cytology optimization in thyroid disorders.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. I'm Mostafa Heidar from Military Medical Academy. Today we'll be talking about fine needle cytology optimization. First, we have a short introduction about the occurrence and prevalence of thyroid nodules, which is the most common indication for fine needle cytology from the thyroid. Thyroid nodules are relatively common pathologies with 34.2% prevalence in population and more dominant in females. Most of these nodules are not malignant and mostly are benign, with malignant prevalence about 1.6 to 12% malignancy. وهو الحقيقه يعني في اهميه الفاين نيدل في قصه ان احنا محتاجين ابروتش مظبوط للدايجنوزز علشان النيولي انفنتد تكنيكس المايكرو المينيمالي انفيزيف تكنيكس اللي اتحطت في التريتمنت بتاع الثايرويد نوديولز زي المايكرويف ابليشن او الليزر او الراديو فريكوانسي وزي الامبولايزيشن وحاجات ثانيه كتير. So you have a great need for accurate evaluation. It depends mainly on ultrasound through TIRADS classification. And after TIRADS, few of these nodules are indicated for further investigation and histopathology, including fine needle cytology. However, fine needle cytology has many challenges. Most of these challenges are due to inadequate sample. While fine needle is a cost-effective, safe, and minimally invasive procedure with very high sensitivity and specificity, however, it has many challenges, including an inadequate sample, which is due to hemorrhage and loss of cellular architecture and cellular trauma. So we need to know how to optimize our fine needle cytology to obtain an adequate diagnostic sample. In my experience, there is a few correctable causes which will yield a better sample. It includes the sampling techniques and the smearing techniques. في جزء من الحاجات ديت حقيقه هتكلم عليها من الاكسبيرينس بتاعتي وفي حاجات جزء من ليها جايد لاينز او ليها بيبرز اتنشرت فيها. اول حاجه الكولد باكس انا ما لقيتش حد بيتكلم عليها كجايد لاينز او بس دي اكسبيرينس يعني من عندي. ابلاينج كولد باكس قبل السامبل بمده 5 دقائق 5 minutes prior to the procedure will lead to less hemorrhagic sample. Also single pathway, when approaching a thyroid nodule, you should enter in a single pathway without too much manipulation to avoid contamination of the needle. And finally, in the sampling technique, which procedure shall we use? Aspiration or non-aspiration technique? And this question we have a study in Maadi Hospital and Aswan Oncology Center, which revealed significant difference in the diagnostic quality of fine needle non-aspiration cytology using only the syringe without applying insection, yielded better results compared to aspiration technique. So it's better to use non-aspiration technique in most of cases. As you can see in this graph, it's comparison between the non-aspiration and aspiration procedures. Diagnostically superior samples were obtained in 60% of the non-aspiration technique, while only 37.5% were obtained in the aspiration technique. 0% were non-diagnostic in the non-aspiration technique, which was maybe due to low population, low cohort, which was 60 patients. In general, using fine needle non-aspiration cytology led to more better results. In smearing techniques, we have two main issues. Since film, we have to smear the sample on the slides to be very thin, and also to avoid crushing of the cells. Avoid crushing the cells. In the end of this lecture, we have a small demonstration, video demonstration for how to acquire using non-aspiration technique and how to smear the sample on the slides without causing a significant crushing of the cells to preserve the cellular architecture. This video how we can use the non-aspiration technique using only the needle, which will be introduced in the patient. And beside better results, it also found that it's more convenient for the patient and for the operator for better handling of the needle. And the next video, how we are smearing the sample. Simply احنا بنحط السلايدز على بعض without applying any pressure وبنسحبهم بعد ما بنفضي السامبل بنسحبهم delicately خالص بحيث ان احنا avoid crushing of the cells زي ما هيبان في الفيديو التاني. No pressure is applied during smearing of the cells of the sample. Okay. After optimization of the fine needle cytology, there is a great debate comparing fine needle cytology to the true cut biopsy. والحقيقه يعني هو ديبيت انا في كل سيشن عن الفاين بتكلم فيه عن فاين نيدل او كده بيكون في بعض الاوبينيونز يعني ان احنا محتاجين نستخدم الترو كات ان جنرال عشان نون دايجنوستيك ايشوز. الحقيقه انا عملت ريسيرش في الافيلبل ليتريتشر وفي الحاجات الموجوده كلها ما لقيتش اي ايفيدنس بيتكلم على ان الترو كات ممكن تكون هي الفيرست لاين دايجنوستيك تول فور ثايرويد نوديولز. بالعكس خالص هو كله بيريزيرف الموضوع للفاين نيدل سايتولوجي وإف it was non-diagnostic it should be revised and repeated, and if also non-diagnostic we can proceed to the true cut cytology. In Journal of Cytology, in a paper published in 2018, there was it was a review paper, a review article comparing all available literature. It found that fine needle cytology has a very high diagnostic accuracy approaching 97%, and sensitivity for detecting malignancy approaching or between 83 and 98%, which is very high. So it was sufficient for diagnosis. However, in non-diagnostic or inconclusive samples, we varied from 5% to 40%, which is a great interval. I think it may be due to improper technique and inexperienced cytopathologist evaluating the sample. So we have to make an audit with the cytopathologist in our centers and check the results to know which is better technique. Also, fine needle was using this, in conjunction with the cell block, which is may be used during the fine needle cytology sampling by rinsing the needle with a special agent. Can completely replace the core needle biopsy because it can also provide immunohistotyping. However, core needle biopsy may be used in some circumstances, which is will be discussed in the next paper, but surely it must be after inadequate sample in fine needle cytology. According to the consensus of the Korean consensus published in 2016, there are certain circumstances that can be used use the true cut needle biopsy, marked in the green, which in cases of non-diagnostic cytology in previous FNA, also in nodules with atypia or undetermined significance in previous FNA, like PESTA system in PESTA classification Psi3. Also, it has the advantage to differentiate encapsulated follicular neoplasm from non-neoplastic nodule, but cannot differentiate follicular thyroid carcinoma from follicular adenoma. It also can be used as an alternative for fine needle aspiration in cases of calcified thyroid nodules with inadequate samples or inadequate cellular yield in the sample. It may achieve non-diagnostic and low rates of inconclusive and non-diagnostic results. However, using it as a first-line diagnostic tool for these nodules is uncertain based on current evidence, which is the most important issue. Also, it may be used core needle biopsy as an alternative to fine needle aspiration cytology in patients with clinical and radiological features of uncommon malignancies, and fine needle cytology were proved to be negative. To sum, the take-home message is fine needle cytology is a minimally invasive technique for management of thyroid diseases requiring accurate evaluation of thyroid pathologies. Also, fine needle cytology is considered an excellent tool for the evaluation of thyroid nodule if utilized properly, and so we have to make proper optimization for our technique. Proper sampling through proper sampling and smearing, which are very important for good diagnostic cytology samples. And true cut needle core biopsy should be used as an alternative for fine needle cytology in certain circumstances, but not to be the first line of treatment. Thank you. Any questions?
شكرا جزيلا. هو هنسأل قبل ولا في الآخر الجلسة خالص الأسئلة؟ الآخر. Okay. Now we